ODYSSEY-HCM trial is a phase 3 randomized controlled trial testing the strategy of using Mavacamten versus placebo for 48 weeks in patients with symptomatic non-obstructive HCM. The trial included 580 patients that were randomized across 201 sites throughout the world, where patients were treated for 48 weeks. The primary endpoints included change from baseline to week 48 in Kansas City Cardiomyopathy Questionnaire, CSS, clinical summary score, as well as a change in peak VO2. Additionally, we measured safety signals and a slew of other secondary endpoints. ODYSSEY-HCM, the baseline demographic suggested a patient population with advanced disease, and it did not meet the primary statistical significance for the primary endpoint for either peak VO2 or the Kansas City cardiomyopathy score. There were trends towards improvement in some secondary endpoints in favor of Mavacamten, but they were not statistically tested. 1 in 5 patients required temporary interruption in LV ejection fraction due to a reduction less than 50%, all of which recovered following the drug interruption. So in summary, ODYSSEY-HCM trial did not show statistical improvement in exercise capacity measured by peak VO2 or patient-reported health outcomes. More data analysis is ongoing to see if there's a subgroup that would improve these findings using Mavacamten. I think the most important thing is presence of LV outflow tract obstruction, which drives a lot of symptoms in obstructive HCM, of which cardiac myosin inhibitor like Mavacamten is highly effective in eliminating or significantly reducing. And a lot of patients with obstructive HCM, so symptoms in HCM can be multifactorial. A lot of it is driven by obstruction, but the diastolic dysfunction, chronotropic incompetence, some of the other scenarios that also cause symptoms, but the improvement seen in reducing obstruction is probably more, and that is probably explains that in order for us to reach clinical significance in terms of the endpoints of exercise capacity or KCCQ, we may need to have the bar, a different bar, or we may have to think about different clinical trial endpoints.